It's so good to see you tonight here supporting NCNW. I'm in the right color tonight. I'm wearing my pink tonight because we are ecstatic about this discussion on breast cancer. So you know how we do. If you are in your chat, go ahead and let us know, where are you calling in from? I see Philly in the house. I see Florida in the house and South Carolina. We've got folks coming in from Baltimore and Maryland and Atlanta. I see you, ATL. Wonderful to have you on tonight. We cannot wait to get into this conversation. Look at all these beautiful sisters and brothers coming in from all over the country. We've got over 220 folks joining us tonight and more to come. I'm Siobhan Arline Bradley, and I am excited to talk about an issue that is near and dear to many of us. I'm going to share very quickly. Today, I actually got my mammogram. It was very timely to have this conversation tonight. And as someone who was background is in public health, I knew I needed to get my mammogram. And I will tell you, when I got my mammogram today, the oncologist team came in and said, you need to come back for an ultrasound. And I remember my heart just literally dropped a few hours ago because I did not know what I was going to hear, how I was going to feel. And in the midst of being the Black patient, there was only one Black woman who was a technician on site, and she stopped what she was doing, turned around and came back to me and said, are you good? Are you okay? So I just want to shout out the sister who knew I needed to hear from her, and praise God, there's no signs of cancer. There's an opportunity now to really give a praise report tonight and talk about why it's so important to have this discussion, because we are worth all of it. So to all the sisters that are online, all of you sisters that are wearing your pink, I see all of our affiliates starting to send some notes in from different sororities and different civic organizations that are part of our affiliates. It's going to be a good one tonight. We got some bad sisters coming on the call to talk to you about some really important things. Now, you know I got to do some PSAs before we get into the conversation. Yes, hallelujah in the chat. I do see you. Do not forget those that have logged in. If you are a follower of NCNW, you know it is Uncommon Height Gala season 2023. It is our time to honor Dr. Dorothy Irene Height. On the evening of December 8th, you can get your ticket now. We have a virtual seat and in-person seats for our biennial fundraiser, the Uncommon Height Gala. We're going to make sure that we get that information in the chat and the Q&A function for you. If you want to buy a ticket, support us, support our programs, you can join us. For those that are members of a section, I see the AKAs and the top ladies coming in. I see you all coming in. If you are a member of NCNW, if you are a part of our affiliates and have been assigned by your section president or your national president, it's time to register for the Affiliates Assembly on December 7th and 8th. All this will take place, the assembly and the gala, at the Gaylord National Harbor. If you've not gotten your ticket, please, please, please click on the links that are going to be made available for you in the chat and in the Q&A function so that you can see your information and book your ticket. We've got a few other announcements for you as well. There are two books that we are promoting. Diva 2.0, written by Shirley Ralph. She has now agreed to give some funds back to NCNW for every sale. And so please use the NCNW book link. We're going to place that in the chat for you tonight, and I'll come back to it at the end before we go. And Speechifying, written by our own past president and chair, Dr. Johnetta Betsch Cole. Please support these sisters and support these books tonight. Last but not least, I want to say we are reinvigorating and getting back together this opportunity to give additional funds to NCNW. Many of you are already members, but on top of your membership, we have a giving opportunity called the President's Circle 2.0. The President's Circle 2.0 is a program for those who may or may not be members, but this is an additional opportunity for you to give annually. If you're given a gift of more than $1,000 or more, that's not your life membership, but an additional $1,000 or more every year, you'll be a part of the President's Circle 2.0. We'll be sending out information about What that means, you'll have access to conversations with your executive leadership. You'll have annual events for the President's Circle. For those of you that have the ability to give more than just your membership, we have an opportunity for you to support as well. Now, tonight is supported by a number of our partners. You're going to hear from some of them. Touch for Life, you'll hear from Laura in a second. Our friends at the Center for Disease Control and Cancer Prevention and Control, can't wait for you to meet the sisters that are on top of the game there. Also, you're gonna hear from Laura, who will talk a little bit about Black Genes Matter, so blackgenesmatter.info, and our friends at Walmart. Our friends at Walmart are also supporting us tonight. So I think I've done almost all the housekeeping tonight. You're gonna hear about an article that was written by one of our own, Rebecca Watson, on our team about AI and breast cancer. We're going to share that link for you tonight. But let's go ahead and get started. I got that in less than 10 minutes. Amen. We are rolling and on time and getting ready to go. I see all of these sorority. Come on, these beautiful affiliates are calling in. It's so good to see you all. Keep putting it in the chat. Keep shouting it out and making sure that we know who is here and who's calling in now. Don't forget, when you have questions, put those in the Q&A function. Put your shout outs and your hallelujahs in the chat, but your questions go in the Q&A function. Now, tonight we're going to start off our conversation with someone who is a leading leader in this space of cancer. She is Dr. Lisa C. Richardson and is the director, I said it, the director of the Division of Cancer Prevention and Control. It is the largest unit within the Center for Disease Control and Prevention's National Center for Chronic Disease Prevention and Health Promotion. As a director of DCPC, she works with partners at national, state, and local levels. I love this, to break down barriers to good health and create opportunities for everyone to live long, healthy lives. And under her leadership, DCP's 4 foundational programs. This is the National Breast and Cervical Cancer Early Detection Program, National Program of Cancer Registries, National Comprehensive Cancer Control Program, and Colorectal Cancer Control Program. They've helped the cancer control community understand, prevent, and control cancer in all populations. Dr. Richardson, she is someone who provides guidance for the division's research agenda. She is also a trained medical oncologist. Come on, somebody. She is a doctor and a doctor. Come on now. She's authored and co-authored more than 150 peer-reviewed journal articles. And she is here tonight to start us off. And then I'm going to introduce the panel afterwards. But without further ado, I want you all to give her a warm NCNW section and affiliate and friends welcome. Dr. Lisa Richardson, thank you for joining us tonight. Please get us started in this conversation. Take it away as we have this discussion.
Well, thank you for that. Thank you for that introduction. And I gotta shorten up that intro so I can have more time to talk to y'all. So I'm gonna share really quickly here. It worked earlier. Can you all see that?
Yes, we can.
So I'm going to try. So 10 minutes is what I was given. I'm going to do my best to get through it so that we can have some time for conversation. To start with, like I said, thanks. I'm going to talk about Black women and some of the differences between Black women and other women with breast cancer. And so really early detection, breast cancer screening finds breast cancers early when they're easier to treat and curable even. The 5-year survival for women with the localized cancer, the very smallest ones, is way over 90%. So we do want to find them when they're small, when they're early, so that the chance of being cured is higher. So these are the risk factors, just briefly, I won't go over them, but the one in particular that I think is overlooked, obviously being a woman, breast cancer is way more common in women, but getting older is the #1 risk factor for getting breast cancer. And we're going to talk about some genes later, gene mutations, but most people or most women don't have a gene that's causing the cancer. Now, there are families where we haven't found a gene, so family history is extremely important. And I like to say it's the first gene test out there is the family history. And if it's very, very strong, it doesn't really matter what the gene tests say. If you have a very strong family history, there's probably something there, and we just haven't found it yet. So why do we screen? Well, because as I said, local cancer, 5-year survival is almost 100%. So if it's a small cancer, stages 1 and 2 without the lymph nodes being positive, survival is better. And treatment is actually less intensive with fewer side effects. So we do like to find things as early as possible. So Siobhan told a very good story. I used to have, crazy, before I went through the menopause, praise Lord, I used to have to get mammograms every 6 months because of the dense breast, the fibrocystic disease. So I understand, I think I've had every procedure on here, but the follow-up after you have an abnormal mammogram, so this is what happens next. Is it an ultrasound? Is it a diagnostic mammogram with, more views, an MRI? I even had the sort of, you guys remember the flying nun, where she would fly like that? So I had the biopsy with the vacuum assisted, where you basically lay on the mammogram table like the flying nun and get the biopsy done. So I think I've had it all, and it really is a challenge. But once you have an abnormal mammogram, you have to follow up. Because cancer screening, and this is my message, we talked earlier about what's the message for colon cancer screening. All things run through the colonoscopy, where they look at the bowel. Well, for cancer screening in general, it's not just a test. You get the test, then based on what you find, we have to move on. Even with a normal test or not abnormal, the next thing is to follow back up in a year or 2 and get it again. So it's a process and it's a cycle. But just this is the thing I think that we don't tell people enough, is that it's not just a test. If we find something, we have to move and we have to do something else. The family, links to family, family links to cancer. As you see here, 5 to 10% of breast cancers are genes. We can find them. About 2/3 are BRCA1 and 2, but the other 1/3 is about, I guess at this point, 15, 16 genes that we found. You always test the person with cancer because that's your best chance to find the gene. But as I said before, family is very important, because 16% are related to if you have a first-degree relative. So it's all not gene. I think it is all gene-based. It's just we haven't found them, as I said earlier. So a little bit about how breast cancer is different in Black women. Even though Black women have a similar incidence, to actually lower, depending on, what year you're looking at, and it's a little bit lower right now, women die 40% more often after the diagnosis if you're African American. When we look at 5-year survival, again, the lowest survival is in African American women compared to, you can see it all right there. I don't have to tell you that. And it's, again, by stage, it's better, but it's worse at every stage. 99% for white women with early stage, 95% for Black women. So it's still something that we are very concerned about, and happy to take any questions later about why that might be. And this is just a summary for you all. You can have this, a summary for later. The references are at the bottom if you want to look these things up. But the breast tissue may be more dense. How that works, it may be that the cancers are hiding in the fibrous dense tissue, or there may be actually something about dense breast that leads to cancer. Again, twice as likely as women under the age of 35 to get the breast cancer, 3 times more likely to die. It does tend to be more aggressive in younger women, all younger women, not just Black women. And again, the same rates of hereditary breast cancer mutations, but Black women are less likely to be offered the testing. So this is really one of those things where we have to understand and be educated so that we know what to ask for when we go to see our providers or the people taking care of us. This is the largest organized screening program in the country. This is the Breast and Cervical Cancer Early Detection Program. Is exclusively for low income uninsured women. So if you know women who don't have health insurance, this is a program that they can go to their state health department, and there's a link at the bottom there. And this is the last slide as well. So if you want to know about the free mammograms, that every state, some tribes, almost all the territories out in the Pacific, if you don't need a mammogram for, you have insurance, you can go to the FDA website and all these links are here for you to go and get the information that you need. But I think that's it. So I think I did it all in maybe less than 10 minutes. I'm not sure. So it's a lot of information.
A lot of information and very helpful. First of all, thank you so much, Dr. Richardson, for getting us set up. And the questions are already coming in. So what I'm going to do is make sure that I introduce our panel together. So team, you all can spotlight Laura and Nikki and Dr. Richardson and myself. That would be great. I want to shout out some of our affiliates that have come in. I see the auxiliary to the National Medical Association is on. I see the top ladies of distinction and our newest affiliate, Jack and Jill of America. I see some J&J moms who are on as well. I am so excited to see this kind of turnout. We have over 300 folks calling from across the country, and we're going to continue with the introductions now. We have a continued panel here that really is going to bring some light to the experiences. I want to introduce Nikki Hayes. Nikki is the branch chief of the Center for Disease Control's Comprehensive Cancer Control Branch. She's been with the DCPC in the agency's NCC DPHP. You know that in the government, we do say letters all the time. That's right. Since 2002. And before joining the CDC, she was a biologist at the NIH and the National Institute of Dental and Craniofacial Research. She also, for more than 10 years, she is currently the chief of the Cancer Control Branch and is responsible for the successful implementation of one of the agency's flagships, the multi-million-dollar cancer prevention and control programs, the Comprehensive Cancer Control Program. Now, she manages several other programs as well. She is, of course, published a number of peer-reviewed manuscripts and articles, and she is someone who is prepared to give us the context as we look at comprehensive cancer control. So, Sister Nikki, thank you so much for joining. And last but certainly not least, someone who I know very well, my link sister, Sister Laura Crandon. She's a member of two of our affiliates. She's a member of Alpha Kappa Alpha, and she's a member of the Links Incorporated, and is a proud breast cancer survivor. We wanted to give you context for the theory, the practice, and the patient's experience. She's the founder and president of Touch for Life, a nonprofit on a mission to increase the breast health IQ of Black, Indigenous, and people of color, and other underserved communities. Now, you're going to hear more about Touch for Life. It's a two-pronged focus to ensure that physicians deliver the breast health care that Black and BIPOC women need, and that women know and advocate for the breast health that they deserve. She is a lifelong Marylander, and she recognizes the disparities in breast cancer detection and treatment, and has been a major leader. She was a healthcare executive at Care First, Blue Cross Blue Shield, and United Healthcare for over 15 years. And she is on the Duke University Fuqua School of Business Healthcare Alumni and Advisory Board. So I'm so excited to have her. And shout out to Columbia, Maryland. We see all the Columbia, Maryland sisters in the house as she is a patient advocate and ready to give us context. So my sisters, this panel is about to get real because Dr. Richardson just gave us some serious information. And I'm going to go to her first because there was something that she said that I want to be sure that we recognize. And you talked about the death rates of Black women in comparison to others. Can you dig a little bit more there for us? Because I need the sisters to understand, what are the numbers saying? Are Black women dying at a higher rate than white women? And I also heard you talk about younger women. So can we do a little bit more clarification there? Because I'm 45 and I was stressed out about the biopsy. And I'm thinking about now sisters who may be asking, am I at risk? So can you talk about that, Dr. Richardson? Let's unmute her. There we go. There we go.
We get the quarter in the jar, okay? Not
there you go. Unmute yourself.
Absolutely. So yes, the breast cancer in Black women tends to be more aggressive. It's more likely to be something called triple negative, which I'm sure all of you all have heard about, which means it doesn't have the hormone receptors nor a protein called HER2, which we treat cancers with. The challenge in the past with that has been that those cancers were more difficult to treat, but there are now drugs that specifically target the BRCA gene defect that can actually treat the cancer much better.
Mm.
What we see as well is that younger Black women tend to get breast cancer at younger ages, about 3 to 4 years on average, younger than white women do.
Wow.
When we look at the data though, so it's deeper than just screening, because when we look at self-reported data, let's say you would, Siobhan, say, I was, had a mammogram today. And if we ask you, when was the last time? You would say, yes, today, or, whatever. But
Mhm.
when we look at those numbers, the numbers are actually equal to a little bit higher for Black women. So it can't be just screening. And again, I think it's the follow-up that has to get done properly. And in a timely way. And then if you are found to have cancer, that you have to get the best treatment possible for the best outcomes, because there's a lot of information out there. And I did some of that research when I was in graduate school, and a little bit after that, is that Black women don't tend to be offered the same level of chemotherapy or quality of care that others are. And it does make a difference. As an oncologist, the first chance you get to treat a cancer is the best chance you get to treat cancer. So you really do have to get quality care and make sure. And the one thing I would say that's not a part of this question, but you talked about it, Siobhan, you have to feel comfortable with your provider. It's your body, it's your life. And if you're not comfortable, move on. There's thousands and thousands and thousands of doctors out there. You can find one that, meets your needs.
I want you to know that the doctor told you to find another doctor. I want you to be released, my sisters. Okay, you can find yourself another doctor if you need to.
Yes.
And I think that is so important. I see all the shout outs in the chat. I see a lot of survivors in the chat. So please tell us if you're a survivor, put survivor in there so we can see you. I see 7-year, 5-year survivor. I see the Women's Missionary Society of the AME Church is on. Oh my gosh, a survivor. I see Iota Phi Lambda, another survivor. We've got a lot of survivors on the calls tonight. And we also, 19 years, 3 years. Come on, congratulations to our sisters who are sharing their story. And I want to open this to a conversation that you brought forth. And I want to open this up to the panel. Dr. Richardson already talked about what happens if there's a normal or abnormal mammogram, what happens after that. We've already answered that question. Sister Nikki, I want to talk about your work, because your work is very, very specific around comprehensive cancer care. Now, that's a lot of context, a lot of letters, but we need to know, what does that mean, and how does your work affect Black women and their access to understanding cancer prevention?
And comprehensive cancer control, first of all, I want to say thank you very much for having us here tonight.
It's beautiful.
And I have to absolutely shout out the survivors. Thank you for your willingness to share. So comprehensive cancer control is everything. It's just that. It's from prevention, which we have tremendous opportunities, all the way to screening and diagnosis and follow-up care if you need it, and treatment, and then survivorship care, which is extremely important, and then palliative care. And so I think, and we work in all of these areas. So if you have an opportunity, and I see all of these beautiful women on the phone, please reach out to your local, every state has a cancer coalition. And I'm asking you right now tonight to reach out to your state's cancer coalition and get involved with your coalition, so that we can make sure that the issues that matter in our community most are absolutely represented in the state's priorities for how we address cancer. I think we have lots of opportunities from prevention. We can teach each other how to drink a little bit more water, sometimes when we can, to exercise a little bit more, to get a little bit more exercise, to cut back on fatty foods, and then we have a rich culture, we have a rich history. And I think the other thing that we can really encourage each other to do, especially as survivors, is talk about it.
Come on.
We have the opportunity to talk about it, and we need to, because you know how we are. Now, we real close with our own business.
Yes.
We tell other folks' business, but we like to keep
about her.
Close. Right. But we cannot do that. In my family, I had an aunt 30 years ago who was one of my favorite aunts, and she died of ovarian cancer.
Wow.
And my grandmother would not let us talk about it. And I asked her, I said, well, what's wrong? And she said, she's got it. She's got the C. And she wouldn't say what the C was. And I said, oh, cancer. And she said, shh, don't say it. Don't say it out loud. And then I said, well, where is it? And she said, it's down there. And she said, we're not going to talk about it. 30 years to the day, her daughter died of breast cancer.
Yeah,
And we didn't know she had breast cancer
right.
until she
Wow.
was in the hospital and she was dying because
Yep.
she didn't want to talk about it. And so her sister and I pledged to each other then that we are going to talk about it
Yeah.
because our
Mhm.
history matters. And
Mhm.
so if I'm able to go to my doctor and say, I've got this history, I need you to be a little bit more aggressive and a little bit more concerned about the things that I tell you concern me. And so
Right.
I think as a community, that's where we have opportunities on the prevention realm as well as on the survivorship realm. We just have the opportunity. And I know to our survivors, surviving anything
Mhm.
is a blessing. It's an absolute blessing, but it's not always easy.
No.
I know it's not easy, but I thank you for being willing to tell your story because
Yes.
that's what we need to know. That's what we need to hear. So I think from a comprehensive perspective,
Yes.
we have lots of work to do. And there are lots of opportunities. So, and I'm glad to be here tonight so we can start talking about it and look forward to opportunities to talking more and sharing more.
Nikki, you
Absolutely.
just set up the
Mhm.
firestorm, honey. Okay. Because our cultural beauty
Yes.
also stands in the way sometimes of our ability to take hold of a situation.
Yes.
A shout out to the survivor. I see you, Lambda Kappa Mu survivor. And there's a sister who just shared in the chat, I'm in treatment right now. So just sending you love right now, Sister Chanel. We see you because this is the moment where we change the narrative. And this is why NCNW wanted to partner with, I want to say that the Black women are at the CDC. Amen. Black women at the CDC, leading divisions, leading this conversation. And I got to come to my girl. Laura Crandon, because let's talk about story. Tell us your story and tell us really how you got to this conversation. Black Genes Matter. I can't wait to hear this conversation because I want the sister to know how you got here. I know some of it, but I'm not going to spill the beans. I'm waiting in anticipation about how you share this story and how you are such a blessing to many of us that know your story. Please share.
Thank you so much for having me and for letting me share my story. And Sister Nikki Hayes is so right. The silence can kill us. So I'm here to break that generational curse here. So for me, it started with what I thought was an all-clear mammogram in 2016. It said dense breast, like Dr. Richardson said. But what I know now and didn't know then is that dense breast means the radiologist can't see. It's like looking for something white in a white cloud. Like the dense tissue is white and so is cancer. And so like 50% of women of color, I was not referred to additional screening, MRI or ultrasound. It just went unabated. Fortunately, I was doing self-exams. So I found something unusual myself. It turned out to be breast cancer. And so I had all the things, chemotherapy, all my hair fell out. I had radiation and I had surgery. I also had the privilege of having this test called a biomarker test for mutations. Dr. Richardson talked about that. Let me tell you, only about maybe 20 to 35% of us are getting these tests. And I think it's criminal, and that's why I'm here. So I got this thing called what they call targeted therapy. It means now that they know what's driving the cancer in me, they can target precision medication specifically to turn off the thing that's promoting cancer in my body. It's personalized or precision oncology. So I had that. And then I thought everything was great. And I developed this headache that I couldn't shake. It was at my brother-in-law's 50th birthday party. I had the Ciroc and cranberry. And my professional drinking cousins thought I was a lightweight. But, I couldn't shake the headache. In fact, I heard sounds that other people didn't hear. And when I went to the hospital, my brain was so swollen from the tumor that my brain, how it's symmetrical, it had done a midline shift. So part of it had moved over to the auditory part of my brain. So I had brain surgery 2 weeks after that, and then had radiation. And I went to my oncologist, to Dr. Richardson's point, community oncologist. And I said, okay, what's next? And the answer was, well, you're a woman of faith. And I said, yes. That was it. So I fired him and I moved on to an academic physician. And that person put me in a clinical trial at NIH, which helped save my life. Also because I knew these biomarkers and mutations, you see, and that makes your treatment really important. And so I got a clinical trial. I've had 3 brain surgeries, actually, including one in March of this year. But that one wasn't so invasive. It's kind of evolved the technology. I was in and out, and it was necrosis. So when you have radiation, sometimes the dead tissue swells in your brain, and so they take that out. But for me, I'm metastatic, which means that I'm on a treatment for the rest of my life. I get 3 infusions every 3 weeks. I get scans every few months, but God has me on this earth because I realize the disparities that Dr. Richardson talked about, that what I received, the treatment, even being offered a clinical trial, we're only about 3% of the clinical trial. So which means some of the medication doesn't work on us because it was never tested on us. It also means our bio data isn't in the science. And so when they're looking for what's driving cancer, you ask like, what's causing this? They don't know because our tissue isn't in there for them to look and find out. And so I realized I'm a unicorn and I couldn't sit still. And that's why I started Touch for Life, to get out and tell this story and say, you deserve to have genetic testing. You deserve to have this biomarker testing, and you better document your family history because that's how your insurance is going to pay for it, because it puts you at a higher risk and it makes you eligible for coverage for things like this. And so that's really the impetus for Black Genes Matter. Black Genes Matter is a movement. It's to get out into the community and tell us, by us, for us, tell our stories and the importance of documenting your family health history. We have a tool on our website, blackgenesmatter.info. It's also important to then, because prostate, remember you inherit 50% of your genes from your mom and 50 from your dad. So if you're on your dad's side, prostate cancer, it's possible you could have inherited a mutation that puts you at risk for breast cancer. Ovarian cancer is a big risk genetically. Pancreatic cancer, a big risk genetically. So knowing these things can help you be able to do something about it. And we want you to know what your rights are, is to be tested, get these answers, and to guide your treatment so you can take advantage of all the advances in cancer therapy and treatment. That's why we exist.
So, you know, after I shout every time I hear this, I go crazy because I know the story and I have seen Laura win. She wins. And we are grateful to God. I see all the shout outs in the chat. You get so much love in the chat, Laura. The love is coming. The thank you, praise God. Yeah, because part of this is about the word that's my favorite word. My folks at NCNW know this. It's the advocacy.
Yes.
It is having an understanding of what my rights are, the kind of access that I should have. Dr. Richardson freed you up and said, leave the doctor that does not serve you appropriately. I want you to know that you tonight are getting the information that you need. Now, there's so much more that we can talk about tonight. I want to get to some more of these questions because they keep coming in and I don't want to miss it. Yes, somebody said Laura wins. Yes. Thank you. Thank you. Jawanda, you just gave us life for that. Laura, you are winning and there's more to be done. Dr. Keith, I believe, is on our board chair. We love her all the way in Atlanta. Shout out to her and our board members that are calling in. Here's a question that came in from our audience. The question is coming in about how we should be getting tested. So we've been talking a lot about family history. We've been talking about genetic testing. The question is, if we are diagnosed at such a higher rate, why is it so hard to get mammograms for some communities? Dr. Richard, can you help us with that? Because we're seeing that there's a challenge for many to get access to this test.
Me? Did you ask me? Okay,
Yes.
Okay. I thought, anyway, I missed the name. So I think some of it is where you are. So let me start over. Cancer screening is usually based on your age. And as you know, the starting age for breast cancer screening is 40. Which is, just about right. Screening works best if cancers are more common in the population.
Yeah.
So if it's not, you get a lot more false positives the younger ages that you go. But again, I think, knowing your breast, knowing what they're like, not being afraid to talk about it with
Yeah.
your doctor either. And again, helping them to understand that if you have a problem, you need to be followed up, right? A lot of cancers in younger women are from symptoms. And actually, for the people on, everyone on the line, the number one, the number one lawsuit against physicians, radiologists, is missed breast cancer.
Ah,
Because they don't listen to women when we come in and say, hey, there's something wrong here. And then they ignore you and say, oh, you're too young, those types of things. So again, to be, your own advocate, what Laura said is absolutely true. But to be your own advocate, you have to be informed. You have to know what to ask for and what to expect. And some of that stuff is on our website as well at CDC. So, and we have a whole slew of materials for younger women who've had breast cancer about family history, about testing. And then if you've survived, like Laura, like you have, you're still living with it. And
yes.
by the way, the miracle of medicine is that if she didn't tell us she had metastatic breast cancer, we would never know.
Right.
No, I mean, from the time I started training in 1992, oh my God. But look at Laura, you look just like me.
Girl, yes.
Looking
Fly.
good.
Fly. Nikki, go ahead. Jump in, Nikki.
I will say this too, and this is to Lisa's point. If it doesn't sit right with you, if your doctor says no,
keep moving.
It doesn't, go to another doctor, and you keep pushing and you keep pushing.
Yes.
My aunt that had the ovarian cancer,
Yep.
whose daughter died of breast cancer, she kept telling her doctor, and he felt like he knew her so well, I just don't feel right. I'm bloated, this, that, and the other.
Yep.
And he kept always, that you're at that age, you're at that age. And she finally said, you know what, I got to go get somebody else. I got to tell somebody else this. And
Yes.
then that doctor did further exams. And then that's when he diagnosed her with ovarian cancer. So if you're looking for a mammogram,
Yes.
to Lisa's point, know your history, know what you're looking for, know what you need to be thinking about. And if what your doctor number one says doesn't set well, that doctor's done. Go to another
Yes.
doctor. And go to another doctor until you get the answer that you're looking for, because you deserve it. You absolutely deserve it.
So Siobhan, that last slide I had
Yes.
2 links there for the FDA, just for regular, like where can you find a mammogram facility? And if women don't have insurance, you can come to the CDC website, and our program is in every state in the country that you can find out where to get a free mammogram.
And I want to say cdc.gov/cancer.
Mhm.
All right, cdc.gov/cancer. Get the information and get your advocacy going. Now, I got a question. I have 3 questions about this, so I'm going to put them all together. It's around dense breasts. The question is, how do I know if I have dense breasts? That's a great question. And what is considered a dense breast? Is it around cup size? Like, what does that mean to have dense breasts?
So Laura, do you want to answer? You actually did a great, it's like looking for the clouds in the clouds. I love that description. So do you want to?
Well, first of all, I want to say that anyone who has gotten a dense breast mammogram, you need to go back to your doctor and ask, what degree of density is it?
Yes.
Because it's sort of like a forecast.
Yes.
You think about, let's say there's a plane in the sky. It's clear. You can see it's a plane. That's clear. Then it could be cloudy. You see a tip of the plane, so you know there's something there. It's a plane, probably. Then it could be mostly cloudy. You can't really see, or it could be overcast. Those are degrees of density. You have the right to know what's the degree of density. It's usually a scale, A, B, C, D. But at any rate, you should ask. And then once you get the answer, you should say, well, should I get some additional screening? Is there something else I should have? I mean, you can have a really respectful conversation with your physician, but you should know there is legislation going through each state legislature that you can advocate for. That's another discussion, to make it mandatory for mammography to tell you the degree of density. Nonetheless, whatever it says, you have the right to know. It's the amount of obstruction that the radiologist can or cannot see. I'm not a physician, so please,
Yeah.
Dr. Lisa.
No,
weigh in.
actually, that's actually beautiful. I like the way you describe the clouds, and because that really is what it's like. So the question started out with, how do I know I have dense breasts? Well,
Yes.
the only way to know is to have the mammogram. So if you haven't had a mammogram, you can't know. But to your point, and it's really about how your breast feels. It's not about cup size. It's just
Okay.
about how the breast looks. And Black women tend to have more dense breasts for whatever reason. And so it is something that you need to follow up, but it's the initial mammogram. And there are states out there where it is mandatory to report breast density on your mammogram to make
Wow.
sure that your mammogram result, to make sure that you know that you have dense breasts, and then you can figure out how, yearly screening, other testing, like you said, Laura, like ultrasound that they may need to do to figure out what's going on, or another mammogram, a diagnostic mammogram or something like that.
And let
And
me
I
just
will
That's how you
say-
describe it. Yeah.
yeah.
And I will say
Good.
that, there are these implicit biases. And
Yes.
so depending on where you go, some physicians may or may not already have in their mind what you came to hear, what you will accept, what you can accept, what you cannot accept. And so
Yes.
to Laura's point, and I really appreciate this, if your doctor tells you you have dense breasts, then yes, ask, well, what is the
What's
density?
next? Right.
Because you want to
Right.
be able to know, like, are you just telling me that because, you're waving off or dismissing
Mm-hmm.
some things or not, because Black women tend to have dense breasts.
Right.
And you can just say that and act like and normalize it so that we
Right.
don't ask questions.
Right.
Or
And
do they
again,
think that your insurance won't pay for it?
Well,
even
I
though
was
Right.
that's
I was
something
getting ready
like
to
That's-
hit the insurance
Right.
piece.
Yeah.
mhm.
That's
because
not true.
That
And there is
today, I had that
legislation,
issue.
again,
right?
going out to cover these types of tests that we need to
Absolutely.
advocate for, too.
3D, there was a 3D opportunity today.
Right.
And they said, I don't, and I can see I don't know, it's a barrier, right?
Yes.
Because if I'm sitting there filling out my paperwork and you say, I don't know if your insurance covers this, it's very likely that I'm not going to check the box for
Check the box.
the 3D.
Exactly.
Mhm.
Exactly.
Mhm.
You
So
deserve 3D. And I
I-
would say, well, let's
yes.
try it out. How about
Right.
you run a sample claim and let's try it out? Or why don't
Right.
and actually just check the box, sisters. How about that? How about we're just gonna check the box? Because at the end of the day, what I realize is this is a real conversation about access to care,
Yes.
about bias in medicine, about bias in
Yes.
practice. And I know I'm a public health degree, so I can
Right.
say certain things that some people may not understand. For my sister who may not have that context,
Mhm.
I want us to inform you tonight, those that are on the line tonight, check
Yes.
the box, say you want all of the screenings. Yes, bring me back for the ultrasound. Thank
Yep.
you for that. I'm looking at my results right now, heterogeneously dense breasts. I
Breasts.
said, okay, that's, and now I'm gonna call them back tomorrow and say, just for
What is
clarity,
that?
what does that mean?
Yeah.
What's
So
the degree
this
of
is the
density?
work.
Yeah.
Right? What does that mean? So I have another question that's important. And Nikki started to bring this up, but I want to dig in a little bit deeper. The
Yeah.
question is, why don't we focus on the nutritional aspect of cancer? Why don't we focus on the nutritional aspect of cancer and promote that more in Black women? Is there some connection here?
Oh,
There
absolutely.
absolutely is.
Yeah.
There's the risk factors include alcohol, excessive alcohol use, tobacco use, diet, lack of physical activity, and poor diet. So and all of these things matter. And it's things that we need to talk about. And and when my grandmother and grandfather were going, they didn't eat processed food. They ate food off the farm. Like, and all summer long, we were pickling and we were canning and we were eating fresh vegetables that were frozen all year. That's not what we have access now to, to. They didn't go to McDonald's and Pizza Hut and this, that, and the other. But diet and physical activity absolutely make a difference. Absolutely make a difference.
So I'd like to add on to that, Siobhan.
Please.
So if you go back, so one of the things I like to do is I like to look back in history to see what happened, like what has happened and what can we learn from that? So if we look at, so there's some data, if you look at death data around cancer between Black people and white people, in the 1950s, there was no difference.
Wow.
So what was different in the 1950s? Exactly what Nikki said. We
Yes.
grew our own food. We were more physically active because we had physically active jobs. But, you know, I'm happy to send you guys that information if you want to see it. But
You
these
do.
changes have come as it's sort of, I think about it like people coming from other countries and acclimating to our society and culture. We as Black people acclimated to the culture in the 50s and 60s. And that's when the rate of cancer and cancer deaths started going up. And the differences were bigger for, you know, for us than they are for white people. So it really is getting back to the good food, exercise. And by the way, I said this on another presentation today. These are the hardest things to do.
Come on.
Exercise, eat right, because it's just so much out there to distract you. The food.
I promise you,
out
because a
there.
French fry is the demon
Baby,
in my life right now. I'm like,
It'll
"Ooh."
solve every problem.
Yes,
And
it
let me
will.
tell you, and this is why thanks for that question about nutrition.
Yeah, thank you.
I think sometimes we focus down on just heart disease and
Right.
diabetes about nutrition. No, all of these chronic diseases that we're speaking of, and as someone I'm like, oh, the pouch, that's not pregnancy anymore. He's 9 now. I can't blame it on the baby anymore. This is not getting the chance to get physically active. The question came in because they heard about 3D. The question was that came in: does the 3D mammogram test show issues beyond density? If there's the dense breast, can a 3D see past the density? It's a great question.
So when we look at the 3D mammogram tends to be more sensitive, which means it finds more, but it also shows more that may not be cancer, which leads to more follow-up. The bottom line is you want to find the cancer.
Yes.
Just be aware that sometimes you may have to follow up and it doesn't turn out to be cancer more often. But the program we have for uninsured women, we cover 3D mammograms because you can hardly get a 2D mammogram anymore. So I'm kind of interested that that they asked you, did you want one? Because most of the places you go now, they don't even offer the 2D anymore because they've moved on to the 3D.
I had to check the box today.
Okay, all right. So that's
I
interesting.
I talked to a woman yesterday who was
Mhm.
asked to prepay.
Oh, wow. Wow.
You're talking
Yeah.
about barriers.
Now that's an access issue, right? Are you
That's
gonna
not
have
acceptable.
$150, $200 to pay on the spot? No.
No, that's not everybody's
I just
story.
imagine the women who turned around.
Yeah, they just walk away. Yeah,
Who will just live with whatever.
whatever. Yeah.
Next question that came in: is the biomarker mutation test for all types of cancers or just breast cancer?
Oh, that is such a great question.
Oh, get ready, Laura Crandon. Okay, come on.
Yeah. Oh, yeah, I get excited about this. So remember there are 2 types. There's the genetic, the kind you inherit from your parents, right? And then the mutation is really not inheritable. It's really based on it's in your tumor. And they find that out typically by a tissue biopsy, and they're kind of dissecting it and seeing what's in it, running all these tests. You really want a comprehensive biomarker mutation. So no, the answer is no. Biomarker mutations are found in many types of cancers.
Yep.
Colon, lung, prostate,
Mhm.
breast. And what's important, especially in lung cancer, is if you're diagnosed with lung cancer,
Mhm.
you need to have that biomarker tested right away.
Yeah.
Because there are certain, if you have a certain regimen of chemotherapy
Right.
off the bat, you can't have the more advanced later on because it's deadly. So it's really important in the beginning, as early as possible, to have the biomarker test. There are also these new tests that are coming out that are called liquid biopsies, circulating tumor DNA, that can also tell whether you have any kind of residual cancer if you've already gone through treatment and therapy.
Mhm.
But the biomarkers are not unique to breast cancer. So,
Right.
and they have these funny names: P10, AKT, ATK1. I don't know who makes this stuff up. It couldn't be more complex. It makes no sense at all. But what we're finding is that some of these, like BRCA2, BRCA2, is in prostate and breast.
Mhm.
it can show up in multiple types of cancer. It's just really important to know which ones you might have so that you
Right.
get the most advanced treatment and in the sequence that you need to have it. But Dr. Richardson, please weigh in.
Oh, no, you're absolutely right. And for something like BRCA mutations, it actually, there's two different types. One's called the somatic mutation, which is actually in the cancer. And then there's one that's the germline mutation, which is the one that you pass through your family.
Yep.
You need to be tested for both. And the cancer, if the cancer has the gene defect, it directs the chemotherapy, what Laura just said, to make sure you get the right treatment.
And
And I-
The good news is there's lots of stuff that's coming
There's a
up.
whole bunch of stuff.
but see, this is what we want to, and this question is specific to that.
Right.
How do we go get that test? Like, how do you get this gene mutation test?
Right, because it's not being offered to us. Yeah.
Correct.
Mhm.
So if you have cancer, the doctors are falling down on the job.
Yes, they are.
Every breast cancer should be tested for BRCA1 and 2. And I think it's probably, Laura, you may know this better than I do at the moment. It's probably less than 50% of breast cancers even are tested for BRCA1.
Oh, yeah, less. Yeah.
Even if it can direct the right treatment, forget
Right.
about family history.
And-
You
Right.
want to get the right treatment when you first get diagnosed. So I think it's really I think it's a systems issue, because if
Yeah.
it was an automatic order, breast cancer test for this, I
Right.
think that would be the way to sort of fix it, because my brain can't hold on to all of this information. So I think it's a systems issue. And also to Nikki's point before, implicit bias of people thinking, what people back in the day when, we were looking at obesity and Black women and, chemotherapy, doctors would just say, we don't think they're going to come back if we give them too much chemotherapy. So they would underdose people. So
Right.
of course you're not going to live as long as you didn't get the best treatment, right? And so it's just really, again, and thank you for having this this webinar, because this is very complicated.
Oh
and,
my gosh.
just to have an opportunity to ask questions and to, present things to people.
Go ahead, Nikki. I
So
see you.
you do
Yeah,
have.
so the,
Oh,
Sorry.
go ahead, Nikki, and then
because
I'll bring
this
Laura.
is complicated, what you've reminded me of is how important caregivers and
Yeah,
caretakers are, and how
exactly.
important survivorship care planning is. And so when you have a diagnosis, it's so important to take someone with you
Yes,
so that they can help you to write it, because it's overwhelming.
yes.
So they can help you to write all of these things down, because you have to be able to keep track
Mhm.
of this and make sure that your entire team is fully
Yes.
aware, not only of what you have, what you're doing, what you did before, what you want to do, what your intentions are. And you have a whole team of folks that are working with you. So making sure that you're taking someone with you to your visits, to these conversations, is extremely important.
So I want to add on to that just briefly.
Yeah, go ahead.
Yeah, just briefly, is that we forget about the caregivers. Please, 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 if you're one of those people, please take care of yourself, because you can't take care of your person if you don't take care of yourself.
Mhm.
And so we sort of put ourselves to the side because we got to get through it for the other person. And then all kinds of crazy stuff happens to their health because they're trying to be there for their person that may have cancer. So sorry, Laura.
So jump in,
Oh,
Laura.
yeah, no worries. I just want to make sure like you should ask your oncologist for the test.
Mhm.
We also have a guide on our website on how to have the conversation with your doctor. It's not
Right.
confrontational. It's really
Mhm.
asking curious questions,
Yes,
like how many genes are you going to test?
yes.
That sort of thing, because that matters. Might I be eligible for these tests? And so we have a way for you to ask those questions of your doctor. There's a guide that we have, whether you have been diagnosed or if you might be at risk and want to get the genetic test. We have both question sets.
Yeah. You're not gonna believe this, but it's 8:26. Not really sure why. We might need a series. I mean, this is just
Mhm.
out of control, and it's making me think we're gonna need to create more platforms this way, because sisters and some brothers who are
Yeah.
on here are asking a boatload of questions.
Mhm.
Yep.
I want to give you all, in our closing, each of you get your closing call to action. And I want to make sure we put back in the chat again, cdc.gov/cancer. Black Genes, that's GENES, blackgenesmatter.info. I got some calls to make tomorrow about my own mammogram. We got a lot of information we want to share with you, but I'll start with Nikki, Laura, and then we'll close out with Dr. Richardson in that order. Give us your call to action.
My
our
call to
listeners.
action is let's talk about it. Let's
Yeah.
talk about it. Talk about it in our family. Talk about it with our providers. Talk about it in our communities, because that's how we make a difference.
Yeah, come on, Laura.
Okay, so God, great. You got to document your family history because that helps you with your screening. You've got to I recommend the genetic test to know your risks so you can do something about it. And then certainly if you've been diagnosed, to ask about the biomarkers. And then we are having a series, a Black Genes Matter series on the 4th Saturday of every month, where we're bringing the badasses from across the country to come talk
Love
to
it.
our people. So,
I love that. And we'll make sure we promote that as well so folks can hear about it. Come on, Dr. Richardson, close us out.
Well, the mind is pretty simple. This is all about you,
Yeah.
right? This is all about you. It's all about your health. Ask the hard questions. To Laura's point, if you're not feeling comfortable, politely, obviously, but this is your health. This is your life. And I would say, just go out there and live it, but also demand that you get the care that you need.
Yeah. So the people have spoken. I guess we're gonna have to do this again. We're catching the fire right now. You need more time for this session. So yes, and don't forget, go to cdc.gov/cancer. Go to Black Genes Matter, GENES matter.info. Please don't forget, check us out on ncnw.org. Sister Sandra said, when is the next session? We will let you know when the next session is. Don't forget to join us at the Uncommon Height Gala, December 8th, 2023. For those that are in sections, don't forget, check to see if you are going to be representing your section at the Assembly, Affiliate Assembly, December 7th and 8th. And do not forget, we've got so much happening at NCNW. Follow us on social media. We are #NCNW Strong. That's our hashtag. Use it tonight. Laura, Nikki, Dr. Richardson, I just want to say this was one of the most touching webinars, because what I feel tonight is we really heard the truth. We heard the perspectives of sisters that look like us, that feel like us, that connect like us. And we heard some praise reports tonight that get us going.
Amen.
I'm about to go finish my water and might take a walk myself because I need to get myself moving. To everybody that joined us, to all of our board members, thank you for coming on. Dr. Keith, I see you, all the leaders, all the affiliates, all the sections from east to west, my sisters. You brought them out tonight. Over 340 people joined us tonight. Great webinar. God bless you. Thank you, our panelists. Thanks to the tech team, NCNW staff. We love you. God bless you. You have a good night, and we'll see you all soon.